Hello, and thank you for joining this webinar, Improving ADSM Completion Rates to Support IAPT Service Delivery and Patient Outcomes, sponsored by Limbic. This webinar was presented by Chaellene Davidson and Ben Carrington from the Limbic team as they share with you their innovative AI chatbot. To see more free content, please do visit the IAPT website at www.iapt-nnf.co.uk.
Okay, well, welcome everyone. Thanks so much for joining us today. I'll get Chaellene to bring the slides up and we'll get underway. Brilliant, thanks Chaellene. So welcome to the latest webinar in the Limbic webinar series. Today, we're going to talk to a couple of things. We're going to talk to a groundbreaking product update that we have for our product Limbic Access. We're going to have a discussion around ADSM's anxiety disorder specific measure administration in IAPT, and link this together with how this product update can support ADSM collection and completion. But first, quickly, we'll do brief introductions. We've already been introduced, but selfishly, we're going to take the time to introduce ourselves again. So I'm Ben. I'm the Director of Special Projects at Limbic. I've been with the company for about 3 years now, working across a variety of areas. And really of relevance to this presentation today, I've been working on our compliance and regulatory strategy and some of the updates that we're going to talk about.
Thanks, Ben. I'm Chaellene Davidson. I'm the Director of Delivery at Limbic with a background in operational transformation, and I support all of our Limbic clients around onboarding, training, and post-go live care.
Brilliant. So we can move the slides forwards, please, and I'll get us with a bit of a scene setter. So for those of you not aware, today we're talking about Limbic Access, which was built in 2020 in collaboration with some IAPT services, really in response to the rising demand and the need to make the referral process more efficient, largely off the back of the coronavirus pandemic. And so it was out of this scenario that Limbic Access was born, really as this kind of engaging, accessible and proactive self-referral chatbot with the idea to boost access and drive patient engagement in referral completion and to kind of help individuals overcome some of the stigma associated with referring into services. So that's where the initial idea came from. And as we work with services to gain a better understanding of the care pathway, Limbic Access actually evolved into kind of front-loading the collection of clinically relevant information to create some administrative and clinical efficiencies at the front end of this care pathway, largely around the processing and the assessment for individuals. And really, as part of this development, we made a very conscious push to become as compliant as possible across a variety of different areas that we needed to be compliant across: data security, clinical risk management, medical device frameworks, which all kind of culminated in us recently achieving the highest ORCA score for a level 4 app or e-triage tool in the mental health space. So that's the widely adopted digital health assessment framework that kind of looks at a combination of things: safety, usability, clinical evidence. So that's just to set the scene on the product we're talking about. Throughout this presentation, we are going to run a few polls to gauge some understanding and encourage some audience participation, because just listening to me drone on is probably a soft form of torture. So the first one will be popping up on your screen via Zoom in a moment. Sarah, if we can get that up, that would be amazing. So these are anonymous, and the first question is: true or false? Digital triage tools can have an impact on dropout rates before assessment, and we'll give 30 seconds or so to get the answers in for this. I feel like I should have a countdown clock going in the background. Okay, Brill, let's end the poll there. It feels about 30 seconds. Okay, and there's the results true. Okay, that's good to see. It was a bit of a loaded question, but like to see everyone's kind of awake and paying attention. Great to see. So yeah, the answer is true. And some of the evidence around this, Chaellene is going to talk to now. So I will hand over to her.
Fantastic. Thank you very much, Ben. So To Ben's point, what we really wanted to do is talk to you a bit more about our product and what's been achieved with our partners over the last couple of years. So we supported over 140,000 referrals into IAPT services. And we're really proud to now be working with over 25% of IAPT services in England. In case you're unaware, Limbic Access performs an eligibility and suitability check near the start of the chatbot flow. So we've supported services to identify over 18,000 ineligible patients who are then signposted to more appropriate services. This has a huge impact on admin capacity, who typically would have had to deal with that eligibility check over a phone call. Our signposting includes default options such as Chaellene or the COOTH for underage patients, and also the local IAPT service finder for any patients who are identified as being out of area. And finally, at the bottom of that slide, you can see that we've also supported services to appropriately triage nearly 16,000 high-risk patients to ensure that they enter into the appropriate duty pathway as identified by the service. These patients are also shown crisis signposting information in the chatbot, as well as being sent an email with some keeping safe information for reference. So on top of these totals that we've just described, we're also the only digital chatbot with real world evidence over the last couple of years in IAPT. And we've broken these down into 4 main categories. So firstly, we've seen a really positive impact on access rates when comparing pre and post implementation referral volumes across multiple services. We've seen 15% improvement versus 6% nationally when comparing services using Limbic and services who haven't yet implemented Limbic. And we've also seen an increase in referrals from underrepresented groups. The example here shows the fact that in one service, they saw 30% more referrals from their BAME ethnicities when using Limbic compared to other referral sources. The second area of impact relates to the quality of the assessment. We saw a 45% decrease in treatment reallocation, and I'm referring to step up and step downs there, which means that we're supporting services to get people into the right treatment pathway first time. And then also by applying a static figure across our Limbic Access services, we estimate that we saved over 30,000 clinical hours. And we're always doing more to qualify this, but we have had lots of feedback that Limbic Access provides a really high quality, contextual and clinical information, which helps the assessing clinician disentangle the patient's primary presenting problem. The third area relates to supporting wider clinical benefits, as identified in a detailed study with one partner IAPT organisation. They saw an 18% reduction in dropouts to the poll that we just covered. They also saw a 53% improvement in their recovery rates, which is pretty outstanding. And that's likely influenced by ensuring that patients are on the right treatment pathway from the outset. And we'll come back to that impact on recovery rates in just a moment when we talk about the new feature update. And finally, we can't forget about patient experience. Across services, we see over 88% patient satisfaction rates. And also, we know that patients who have started the referral typically go through all the way to complete them. And that's a testament to giving the patients a really easy and accessible experience to complete their referral. The next slide shows you a few quotes, which I'll let you read, but they are really typical of what we see across all of our IAPT services. We also do regular thematic analysis from our chatbot results based on a free text question, which comes at the end of our chatbot flow. And we can theme the feedback into 3 main areas. The first is about the actual interface, the fact that it looks engaging. We're very design focused, and we use that conversational element to mimic a human conversation, alongside prompts and guidance. And of course, there's the ability for users to complete that on their mobile, which is often taken up. It's really simple and easy to use. So we have pre-populated answers and interactive slides to send responses. And we've worked an awful lot with our clinical and our patient user groups to make sure that we've got the right empathetic tone throughout the chatbot as well. So that's a bit about where we've got to date. What we really want to do is talk to you about kind of what's coming and what our new innovation is. So that brings me on to poll number 2. The question here is true or false? Does ADSM collection boost patient recovery rates? So Sarah, if I could have second poll, wonderful, thank you very much. Again, I'll give you 30 seconds or so. So the question there is, does ADSM collection boost recovery rates? I can see 100% have answered, fantastic. So we've got 88% saying true, 13% saying false. There's a little bit of movement there, but that's perfect. Thank you very much. Happy to close that poll. The answer is absolutely true. And I'll take you through some of the evidence around that in just a moment. So there are your results. Perfect. Thank you very much. Happy to close that poll. So the answer there is true. Absolutely. They do help to boost recovery rates. Thank you. Okay, so let's move forward then. What does that link look like and where does it come from? So firstly, ADSMs, if you've not heard of the acronym before, they are anxiety disorder specific measures. So basically they're validated questionnaires which provide more information to the clinician about the patient's primary presenting symptoms and their history. So we've got a few things to note here for context. First of all, research has shown that mental health practitioners are relatively good at detecting depression, but often miss the complexity involved in anxiety disorders. The IAPT manual details the importance of a clinician ensuring that the appropriate outcome measure has been selected during the assessment process. In light of this, patients being treated for a specific anxiety disorder should have paired scores, with the first one being conducted at the start of treatment. And the statistic there says that less than 25% of people will have their condition recognised by a professional in their lifetime if they suffer with anxiety. The second point to mention here is that the risk that we're trying to avoid is starting the patient on the wrong course of treatment. Studies have been conducted which demonstrate that a patient may be offered the incorrect treatment if the most appropriate outcome measure wasn't used at the outset. This obviously also hampers the clinician's attempt to help the person overcome their problems and symptoms. Studies have also shown that clinicians who were only guided by the minimum data set, so I'm talking there about the GAD for generalized anxiety and the PHQ for depression, they might be tempted to discharge patients before they fully benefited from their therapy sessions. Obviously, nobody wants to do that, but they're unaware that they're doing so because they've only had a limited amount of information to go off at the time for decision making. So using an appropriate ADSM ensures patients receive the most appropriate therapy and then also safeguards against early discharge and adverse consequences that come with that. And finally, you may or may not be aware that IAPT services nationally have a sequin goal. So sequins are all around commissioning for quality and innovation. And the goal from the national team is that 65% of patients should have paired ADSM measures. The national team provides some payment for this as an incentive. So there's 30%, there's some payment for 30% paired ADSMs, rising to the full payment for 65% and above. So it's really clear that this continues to be a national policy priority. And we're also really well timed to be speaking about this with you today because there's also a webinar by David Clark on this exact topic in a couple of weeks. So all in all, there is vast room for improvement, and that's where our new product feature comes in. So before I hand back over to Ben, we do have one more poll for you to just double check where we're up to. So poll 3 is true or false. If a product is classified as a medical device, does that mean that that product is risky? So Sarah, if we could have the third and final poll for guests. So lots of answers coming in there. Fantastic. So we've got most of you in there, so I'm going to end that poll and let's have a look at the results. So 12% of you said that's true, that if a product is classified as a medical device, it means the product is risky. 88% of you, though, said false. So to go through that answer in more detail, I'm going to pass back to Ben.
Brilliant. Thanks, Chaellene. I was just getting the polls out of the way. Here we go. Okay, interesting answer. So what I'm actually going to do I'm going to park that poll for a minute and return to it in a moment, but interesting to see the result. What I want to do is pick up and return to that ADSM thread, because this is really the why behind the innovation that we've created and the innovation that we're so excited about and what we're kind of going to talk through today. So as we've seen, ADSM collection is a core priority in the NHS. And with where Limbic access sits in the care pathway at the front end of this funnel, we felt like we could do something to support this. And so what I'm going to talk to is how we approach tackling this area of need, and what we needed to achieve and how we went about achieving it. So on the left here, you can see the quote unquote, the current version of the product, sitting as this kind of accessible front door on the relevant platforms and areas, and the checks and boxes we got here. So proactively providing an eligibility screen and signposting therein, hooking up with the NHS spine, ensuring that only the appropriate referrals make it into the admin's inbox, and those who aren't receive the information they need to get them to the right place. Then the next area around collecting all the relevant intake information for the service. And finally, as I discussed right at the top, this idea of kind of front loading clinically relevant information in the form of the MDS, the minimum data set in IAPT. With all this information being kind of packaged and passed through interoperability with the Desire patient management system to support a human-led, high-quality IAPT compliant assessment. So that's what we were doing. So the thinking was, if paired ADSM collection is important, we can support the first collection at the point where the service user is theoretically kind of most engaged and highly motivated, i.e. when they are referring into the service. So the leap we had to make here, and it's kind of shown in the blue box, is we need to find a way of collecting the ADSMs at this point in time, at the point of referral, which comes with its own technical challenge. We can't ask every ADSM to every service user. It's completely impractical, it's reckless, user experience is terrible, these are long questionnaires in places. So there has to be some form of selection. Limbic access must be deciding to some extent which questionnaires to administer. And so when we looked at this problem, there were broadly two ways we could do this, using a kind of rule-based if-else logic, or through the use of machine learning. Now, machine learning models in this context will have vastly superior performance than their rule-based counterparts, given the complexity of the context and the parameters and the inputs at play here. So we decided, with the help of our kind of world-class AI and research team, that we would build a machine learning model to support the selection and the administration of these measures. So that's the technical challenge. But it also created or threw up a different challenge, a regulatory challenge. If we're using machine learning in this way, in this context, it's going to be the most, or give the most effective performance over a rule-based system. But this improved functionality means that the product would actually have to be regulated as a class 2 medical device under the medical device legislation set out in the UK and overseen by the MHRA. Now, I can't speak in great depth to the technical developments and how we overcame the technical challenges, as I'm not an ML scientist, but I can kind of talk to the outcome more broadly. So it's suffice to say that we were able to achieve and develop a machine learning algorithm to perform this kind of function with outstanding technical performance, which really, I guess, was the driver of then going ahead with the regulatory challenge. What I can speak to with authority is the work that went into that regulatory side of the puzzle. So if I could have the next slide, please. Thank you very much. So there was a mountain we climbed to get this functionality, this machine learning model for the selection and the administration of ADSM safely incorporated into the product and to get it verified. So lots of hard work went pouring into getting class 2 compliant for this new functionality. And getting class 2 compliant looks like several different things. I'm going to park the actual medical device bit and the actual product for the moment, but you have to do a number of things on top of that. You have to build an ISO 13485 compliant quality management system. This sounds like jargon, it is, but this is a system really, or a certification that shows you have the machinery and the processes in place to safely build a medical device, in this context, a software medical device, more generally at the holistic level. We also had to do some work on additional risk management. So many of you will be familiar with the DCB standard of clinical risk management in the NHS, but above and beyond this, there's a medical device risk management standard 14971 that is similar to the DCB in areas, but also has some additional factors and additional things you need to consider and you need to do as part of your risk mitigation activity. So we had to do kind of this one piece around building the framework and the blueprint and the machinery in this aspect. And of course, we had to focus on the actual building of the medical device and building the technical file for the medical device, which is all of the information required in order to demonstrate conformity and to demonstrate compliance and to the medical device standards here in the UK. So we obviously put that information together, and I won't bore you with the details because it's a lot of documentation. And we went through 9 days of external audit with a UK approved body and their team of software and AI experts. And these are independent organizations that act on behalf of the MHRA, who are the ultimate governing body, specifically to conduct medical device audits and really verify your product. So they are the only organizations in the world that are really specialized in medical device audits, and they operate around the world in a variety of different medical device geographic markets. And ultimately, alongside the overarching legislative body, such as the MHRA, they have the authority to determine what is and isn't a medical device, and if a medical device is safe or not. And really, these audits are all about validation. So as part of our submission, which was over 6,000 pages, they kind of looked through everything. They look at, and some of these are kind of listed on the left here, the actual code base. So is the code built in a safe way using the highest standard kind of coding development practices? They look at all the testing we've done on product performance. You know, this could be loading speeds, browser testing, all of these different elements that go in putting the product together. They look at the usability testing that you have to run. So we did a lot of usability testing with both patients and clinicians. And so they look at this to say, have you designed and executed these usability studies in the best way possible? And more importantly, has the information you've gathered from these usability studies, has that made it into kind of informing product developments to make the product kind of better and safer? Of course, they took a look into the machine learning model in and of itself. So how it was built, the data it was built on, how it was trained, how the model performed in isolation, how it performed when we put it into the product, because they're two different things. You can build a machine learning model on a local system, but how it operates in that environment versus the kind of intended environment could be very different. So they look through all of that and really spend a lot of time verifying that the performance of the machine learning model was accurate and it was operating safely. They looked at all the clinical evidence we'd amassed. So a lot of the things that Chaellene spoke to earlier on, they took a look through. They looked through the studies, they looked through the raw data, and they made sure that the clinical evidence that we were talking to and we were claiming was correct and accurately reflected. And of course, finally, they looked through all of our risk management activities, which are really one of the core components of the medical device certification, is the mitigations you put in place for potential risks of the product, and ensuring and proving that those mitigations hold in the real environment. And kind of coming back to the poll question, that's kind of really what the conversation around risk of medical device is all about. And I was really glad to see the kind of result of that poll, because a lot of the time there can be some confusion around the medical device classifications and rules, but also around the inherent risk of medical devices. And I think that speaks to some of the opacity and of the regulation in of itself, that it's not particularly accessible. But really at the top level, medical device classification is related to the medical purpose of the product, which of course factors in risk. So, you know, you've got in the UK and the UK MDR, and it's a similar across in Europe and the US as well. You typically have 3 tiers. So you've got your class 1 your class 2 split into 1 or 2 tiers, and your class 3. And so, you know, defibrillators and pacemakers, for example, are class 3 medical devices, whereas wheelchairs are class 1 medical devices. Now that is based on their medical purpose, but of course that factors in risk, i.e. if this thing was to go wrong, what is going to be the impact on the patient? But the regulation is in place to make sure that these higher class devices, or these devices in general, aren't risky. It's to make sure that you know, these things don't go wrong with, say, a defibrillator or a pacemaker, by having them validated, by having them kind of looked over, and by having them comply to all these standards. So great to see from the result of the poll, but really it's something that I'm extremely passionate about, is that medical devices aren't inherently risky. They're actually the opposite. They're actually safer, and that's because you put all of these safeguards, these checks, and these mitigations in place that kind of drastically reduce the risk of anything going wrong. I guess that the kicker is really, after this whole process that I've just kind of been describing, we finally got there, and we were able to achieve certification as a class 2A medical device with the UKCA stamp in the UK, which is a world first for a mental health AI chatbot. It's a world first for a psychological assessment software in mental health, which is a broad bucket code used by the MHRA for kind of coding up medical devices. Currently they're on the market with only the 5th clinical decision support tool in this class 2A bracket, and the 1st in mental health as well. So we're obviously super excited about this news. And so we have a super shiny announcement video that we'd like to share with you that goes alongside this, that I had no hand in designing. Otherwise it would have been done in Paint. So here it is. There we go. I could have narrated over the top of that, but it probably wouldn't have been good and a bit weird. So I guess in summary, we are delighted to launch our update to Limbic Access as a fully fledged, fully stamped and approved class 2A medical device, using artificial intelligence that's safe and accurate at collecting ADSM information to support more informed and higher quality assessments. And of course, all in this framework of being in compliance with IAPT. So to finish off, we'll bring it back to the ADSM theme that we've been talking to, and I'll hand back to Chaellene.
Thank you very much, Ben. So we've now talked about the evidence that we've accumulated to date. We've talked about the Class 2 certification, how that was produced and what that means. And then to Ben's point, we really wanted to bring it back to collection of those ADSMs. So we know now that they're really important. We have studies and evidence to corroborate that, but how will this work in the Limbic Access chatbot? So Limbic Access, in terms of this being a new feature, will be able to support services now to get even better information to help them target those presenting problems. For clinicians, they'll receive scores on more detailed measures, and they'll be able to have more information to guide decision-making about the most appropriate treatment pathway. So also thinking about the impact on the clinical workforce, I know that's something that comes up quite a lot. And at Limbic, we're always really passionate to do as much as possible in regard to supporting our clinical workforce. We've had lots of feedback from current services that we can reduce stress levels for assessing clinicians conducting assessments, because firstly, they have more information before they interact with the patient. So they go in with a clearer idea about what to expect. And secondly, they have a suggested care pathway based on that primary presenting problem identified and any kind of tags or risk factors that have also been identified as part of the chatbot process. So we're guiding them with the highest quality information possible for them to go away and validate that initial hypothesis, essentially, that limbic access has been able to provide. Secondly, we should see even more of an impact on those recovery rates. So it's really clear that there's a link between improved triage processes, improved symptom management, and then improved recovery rates. So we'll continue to guide our services alongside this. And what we're really trying to get over the next period is a wealth of evidence that supports these links. And of course, we'll keep on linking that back with regional and national policy teams as well. And then lastly, there's also that financial incentive that I mentioned earlier. So in regard to that financial incentive called that sequin for ADSMs, we know that there is full payment of up to 0.25% of an IAPT service provider's contract with their commissioner if they are getting in those paired ADSMs as per national best practice. So this is paid from the national team to the commissioner and passed on to the provider for service improvement. So all in all, not only are we delivering clinical effectiveness, we also have this new digital innovation that supports financial sustainability as well. So we're really keen to see how that goes with our partner services going forward. So I hope the information to date has helped to tell you, firstly, about what our new product feature update is, to talk to you about the link between ADSM and ADSM collection and treatment outcomes, and then to really show you how the Limbic Access chatbot will be driving towards that improvement in treatment outcomes. So in summary, we're really proud to keep on reiterating that we're the first and only Class 2 mental health e-triage chatbot, and we're sure that that new feature will support further service, quality, improvement, and better clinical effectiveness as well. That's the majority of what we wanted to talk to you about today. We're actually really good for time, and I can see a lot of questions and comments in the Q&A, so great that we've able to have the time to be able to take those questions from you. In the meantime, I just wanted to let everybody know that please do contact us with any additional questions you have, any feedback, or any reactions. We'd love to hear what you're thinking about all of this. So you've got Ben's address there and myself, or feel free to contact any of the Limbic team who you might have come into play with. So for now, I will hand back to the presenters, and I would love to hear any reactions or questions that you might have for Ben or myself. Thank you.
Thanks so much, Chaellene. That was really interesting. And Ben, I too am also a master of paint and nothing else, so don't worry. I've got the questions here on a side screen, so that's where I'll be looking. Firstly, Gavin Tucker took the time to ask quite a long question, but bear with me. So he is a clinical fellow at NICE, but a psychiatrist by background. He asks, what is your system for detecting safety signals? Your Rollwich et al. Preprint doesn't discuss any recording of adverse events or serious adverse events. Thinking about how patients who may not be able to put on inappropriately low intensity programs compared to their actual need. Also, have you analysed the effect on waiting times? If referral rates end up being higher by 15%, the demand for a scarce resource also becomes higher and can potentially lengthen time for treatment. It is in the Q&A box as well, if you'd like to read along.
Okay, I need to find out. So I was trying to intently listen to there. To tackle, excuse me, last bit first, around the increase in referral rates and the impact on demand. Absolutely, that's a consideration. I think thinking back since when we launched this, some of the learnings we had is alongside Limbic Access, there can be a bit of a digital transformation piece as well, and around setting up services so that they're able to, I guess, optimize the service alongside adding something like a front end kind of product or this digital front door like Limbic Access. So it's a really good point. It's something that we can continue to look to with our services, and we're doing more research kind of in this space. The bit around, think about, was it patients who are put on inappropriately low intensity programs compared to the actual needs? So I guess, unless I'm misunderstanding, what I would point to here is the fact that Limbic is still, like, it's not making the triaging decision. There is still a human-led assessment, a component as part of this. And so whilst we're providing information to support that, it's ultimately at the decision of the clinician. And we've done some work as part of the usability studies to look at the impact of Limbic on and the referral information provided by Limbic on biasing treatment decision making, and found no such thing. And that was actually part of our submission as part of the medical device audit. So it's all going through a human-led assessment in order to prioritize and put individuals onto the right treatment pathway.
Thank you. I am going to ask you perhaps a shorter question about your pricing. Someone's asked what the pricing of your Class 2 product is. Price-wise,
is that one for you or for me?
Yeah, happy to take this one. There's no change for any of our current customers with this new feature update. So we're really obviously just passionate about working with the system. That's why we came into business, is what we continue to do. So this isn't a kind of a commercial play to such, and where pricing would be changing anytime soon. It's really about just making sure that we're giving services the highest quality referral information possible, and our new feature update should help them get even higher quality information.
Brilliant. Thanks, guys. So the next question asks about research studies. They say that you showed us one research study on decreased in dropout rates. Is it publicly available, and where could they find it?
Yeah, good question. So it's currently with peer review publication, as many of you know. With this, it takes time. You know, we're putting all of our research through these peer review publications, so it takes time for that information to kind of come out in the public domain. But as soon as it is, we'll be sharing it with the community.
Yeah, absolutely. And then can you briefly say what other decision tools are in this class? They say that they appreciate that you said that Limbic is the only mental health one.
In terms, so in the mental health space, at Class 2A is a psychological assessment support tool. There is none. So none. But in terms of wider decision support tools, I mean, firstly, actually, the MHRA have a publicly available database where you can go and look up all this stuff. So I recommend going and doing that. When we're looking at it currently on the market, that the first in mental health. I think there are others in a lot of the imaging space. So there's a lot that are using artificial intelligence to analyze images such as cancer scans or retinal scans and using that information. But yeah, highly recommend going to the MHRA medical device database, and you can find and search all that information.
That's brilliant. I think actually that also feeds into really nicely into the question of, can you explain more about the difference between Class 1 and Class 2 medical devices?
Yes, absolutely. So as I kind of alluded to a bit, the main difference is obviously in the purpose of the device. That's how classification works, is on the intended use, the medical purpose, and the indications for use, and who's using the product. So that's the fundamental difference, I think. In terms of actual assessment routes, there's differences, or there's additional hoops or boxes you need to tick for Class 2. For example, you have to have an ISO 13485 compliant quality management system in place. There are additional standards around labeling and things like that you have to be compliant with. And the main one is you have to go through the external audit. So Class 1 devices are self-certified devices. You upload your declaration of conformity to the MHRA, whereas for Class 2 and above, you need to go through external audit before you can declare with the governing body.
Thank you. I think actually this feeds onto a really nice and potentially juicy question. about the feature update and whether or not it's been discussed with the national team and what their thoughts were, if it has been.
We do love a juicy question, Vanessa.
I
know. So yes is the answer. So our CEO, Ross Harper, did have a conversation with the national policy team around this. And this was really to make sure that we had we had aligned kind of communications about the policy direction going forward, especially in regard to how assessments are conducted and also the completion of those paired ADSM scores. So yes, we have had a conversation with the national team, and I think what we're really keen to do is keep on building on the wealth of evidence that we have to date. So I think ongoing relationships and partnerships, and how we can also be collecting data and research about and insights really about digital innovation, and passing that back to our regional and national teams. I think that's the best way that we can continue going forward. But in short answer, Vanessa, yes, we did, absolutely.
Thank you so much. I was hoping for some Love Island style gossip there, but perhaps not. The next question is, how do you manage clinical risk, for example, suicide, risk to others within the chat box? And then someone's fed back and said that they're also interested in this. What happens if someone provides answers that are indicative of immediate risk?
Yeah, really good question. So I think the first place to start here is Limbic Access is not a risk assessment tool. So we are not providing any form of risk assessment. I think that's a whole different conversation around a standardized evidence base in that space. So the way we've currently built the product, and we did this alongside a number of clinical leads at IAPT services when we were developing and iterating on this product, and kind of spoke to the first bit of development we did, is the thesis is that we provide ample opportunity throughout an individual's interaction with the bot for them to self-report these kind of symptoms or anything that may be an indication of risk, and we're there to provide immediate signposting in that moment so that they get the resources that they need. And if they're through the referral process, this information is always passed to the service as well, so they can make an informed decision around potential prioritization of that individual. So yeah, that's currently how we're kind of framing it.
Brilliant, thank you. So the next question is about your product. Is it applicable to non-IAPT services? And then by extension, and to be clear, they mean outside of England and outside of IAPT.
Interesting. So first part, yes. So the product and the classification isn't specifically related to IAPT. It's related to all kind of mental health care settings. The second part, was it outside of England? Was asked there. Okay, so this is an interesting one. So it is a UKCA marked product, and you'll see this a lot. UKCA is literally the stamp that you have to affix. You have to put this stamp on your product, either physically or digitally, and that means that the UKCA mark means that you can sell it in England, Wales, and Scotland, and then you need a UKNI mark to go to Northern Ireland. So it's equivalent. You see a lot of anything from TVs to Happy Meal toys. You see the CE mark, which means it's applicable in Europe. So we're UKCA marked, which means it can be used in England, Scotland, and Wales.
Thank you. Do you have any plans to go any further? Do you know?
There are lots of plans in the pipeline to go further. Yes, absolutely. I will have to stay tight-lipped on those, however, Vanessa. Thank you for probing.
Do we have any information about patients' tolerance for also completing the ADSMs?
Yes, we do. And this was part of the evidence that we had to submit when we were actually going for the Class 2 certification. So we had to do usability testing, not just with clinicians, but also with some patients. So in terms of their tolerance, we're really, really aware, and I work on the delivery side, so one of the metrics that we're always looking at is kind of conversion rates and dropout rates and length of time it takes someone to complete a chatbot. So we're really aware that there might be a trade-off sometimes in terms of asking lots of additional questions and the time that it would take somebody to complete the chatbot. As part of the ADSM usability study, we saw that it might take up to 5 additional minutes to complete the ADSM. But what's really interesting is that that's within the variance that we see between our services in terms of the average time taken to complete the chatbot. So we're already seeing that variance at the moment, and that hasn't had any kind of significant impact on any dropout rates or the percentage of people who do complete onwards. So I think that, yes, we're really mindful of the time it takes to complete the chatbot, and with all of our services, it'll be one of the kind of key KPIs that we keep on reporting, and we can come back to post go live and just check that it's appropriate. But also, I think what's really important to hammer home is that in all of the research that we've done, we've not seen a statistical correlation between the length of time to complete the chatbot and the actual completion rates. So that's something we'll keep an eye on, but it's not something that we have any kind of cause for concern on at the moment.
That's brilliant, thank you. So we've got a few more questions left, but we do have some more time. So if you'd like to write any in, I'll be sure to answer them, ask them for you. If you use Limbic Access with the new ADSM functionality, do you know how much time it would save for a clinician conducting assessments?
Yeah, good question. So we have done a study with the previous version of Limbic Access with one provider. So it's one provider study, but across multiple geographic areas, where we saw something like a 12-minute saving per assessment. Again, that's for a specific service, so that might not be totally representative. But I guess we can hypothesize from that, because of the length of the ADSM to complete, that actually collecting the relevant ones up front might save time at the assessment. So this might hold or improve in terms of the time saving, but I guess ultimately the focus is really on the product providing the relevant information to improve the quality of the assessment, rather than just optimize for the speed. And so that's something that will, the quality of the assessment is something we will continue to look into and to track and to monitor. And that includes several things, including time. But we're driven to do research and kind of share the insights we uncover. So we'll be running studies on this stuff, and like the things we presented today, anything that we find we'll gather and report back to the community on what we find. But I guess as a short answer, hypothesis is yes, we think that it could potentially save in the magnitude of that time, but we need to test and do more research to prove that.
Brilliant. Thank you, Ben. So there's another question about pricing, and then a further question about demos. And I know how enthusiastic Limbic would be to show you demos. So Zora's kindly put a comment in there. So for any other watchers today or attendees, please do look at Zora's comment in the Q&A box, because I know that they would absolutely be delighted to show you a demo of their product. But for a service without this product at all, what's the pricing?
So for anybody who's listening and doesn't have this yet, I think the best thing to do is that we'd love to give you a demo and really talk you through the detail, really. So I think rather than getting into kind of nuts and bolts on a call, what we'd love to do is start properly with a demo, make sure that you've seen all of the additional functionality that we've not had time to talk to today. And then we've got fantastic sales partnerships leads, and you can basically speak to who in the team you feel you need to be able to answer any questions that you might have. But we'd love to have that conversation, so please get in touch.
Yeah, that's true. And as I say, Zora's email is in the Q&A box, and they would love to show you the demo. It's impressive stuff. So that is the end of your Q&A session. Thank you so much for what was a really interesting and exciting, what great news that you guys have got.